So I sent around an email yesterday about which chapters we're going to be reading, and appreciate that was a lot of chapters that with not a lot of warning. So apologies, and obviously we're just going to have a pretty casual discussion today, and not I won't ask too much of you, hopefully, except for Josh and Max, who are my favourite people to pick on. Amandine, I'll start picking on you too soon once you unmute yourself. So these chapters we're kind of just working our way through Edinger, but these chapters were the beginning of the nutritional section, and essentially the beginning of every section of Edinger. There's just so much fluff, so it was a lot to read and took up a lot of time, that without actually much substance. Max, I didn't give you much warning either. Did you get around to reading? Hey.
Did I get around those chapters?
Yeah.
Not this time.
No.
Yeah, I've been quite busy. So.
Yeah, no, they were pretty hard to get through. I'm really sorry. I'm actually just going to run and grab a tissue before we start. Sorry.
Hey, Max, I didn't get to read it either.
Yeah.
My excuse is I haven't got the current edition.
Oh.
Okay. Me neither.
I still should have read the old one, but see how things have changed in the last, 10 years?
Do you know
I think
what?
they have.
Jeff, I don't know how much they have actually. Because I obviously studied before the most recent episode.
Yes.
Edition of Edinger's been released, and like my notes from this one are almost exactly the same as my notes from the old one. But I did read the new one this time round.
Well, that blows that excuse anyway.
Yeah. Yeah, that's right. Yeah, next time I'll call and I'll start asking you questions.
No, you don't have to do that.
I don't know if everybody's met Alex, who's on the screen with Josh today. Alex is our new intern. So there's more and more people for me to pick on joining these rounds, which is really nice. But I won't pick on you today.
Okay. Hello.
So I think like the chapters were how to assess nutrition of the neonate and pediatric nutrition of healthy adult dogs, nutrition of the canine athlete, nutrition of healthy adult cats, nutrition of geriatric cats and dogs, and then obesity. And I have to say, like, whilst it was kind of a little bit interesting and there was maybe a point or two in each chapter that I took out of the first 6 chapters, definitely obesity was the one that I think is most clinically relevant. So I might just skip talking about those, and we can go back to the interesting points if we get through obesity. But I thought we'd just start with, like, clinically, when do you guys see obesity having a clinical impact on the health of a patient? What disease processes?
Probably arthritis is one of the main ones.
Arthritis.
Yeah, joints.
Yeah, totally agree. Yeah. So I'm going to skip forward, and why don't we just talk about how obesity contributes to degeneration of joints? Can't find it. Never mind. No, I can. Got it. So I actually thought this was really interesting because my sort of, I guess, understanding of the way that being overweight contributes to joint degeneration was just increased wear and tear on the joints, right? Like increased strain. This is actually a direct contribution of leptin, which is one of the hormones in obesity, which is increased in obesity. So leptin actually directly increases cartilage degeneration or degradation. So it breaks down cartilage. So the idea of this is that the breaking down of cartilage stimulates growth factors and improves cartilage repair in the short term. So it has a functional purpose. But what happens over long term is that increasing growth factor production increases bony spur formation and osteophytes. So we get increased bony changes in those joints, which are deleterious in the long run. associated with increased leptin levels. So I just thought that was a really interesting kind of, oh, that's why sort of point. What other body systems or disease processes do we see obesity impact?
Locked cats.
Locked cats, really good. They didn't have that in the textbook.
Whoops.
Absolutely. So stress-induced cystitis or idiopathic cystitis in cats is absolutely overrepresented in D-sex males and with obesity, and they didn't mention that at all, actually.
Yeah.
Probably because they don't understand the mechanism behind it.
Well, there was a study some time ago. It was only one paper that I quote out of New Zealand, I think it was, that showed that locked cats were more common with things such as indoor cats, wet weather, things like that. Now, in other words, lack of exercise, lack of opportunity to urinate, and going back to the obesity, like the joint things, the joints depend on being used in order to pump fluids around them. This is a bit crude, but and to nourish them. So a fat animal isn't able to exercise because of the cardiovascular effects. They get too puffed too quickly, sort of thing.
Yeah, absolutely.
So then that contributes.
Yeah.
But I think, because it's off subject a bit, but obesity, as I see it, is quite often a disease of owner's perception. Of late that I've degenerated back to general practice. I can have people bring dogs in, and I say, well, this dog's overweight. She said, yes, he's a few kilos over. I said, well, he's not quite morbidly obese, but just obese, and it might be a 35 kilo cattle dog. And I point out to them, we had a cattle dog and she was 17. People just don't perceive what the norm is or should be.
I agree, absolutely. I think owner perception's a big, and the lack of owner understanding of the impact of obesity is a really big problem. But I often say to people, and I warn them that I say I'm going to be really rude right now, but if I'm looking at a kind of, average female, I'll say your dog is the equivalent of you weighing 100 kilos if they're 25% overweight. And that really hits home. I don't do it very often, but when I really need somebody to make them lose weight, I'm pretty harsh.
I try to. That's interesting. I might try that, because I try to avoid that, because quite often you wonder how you convince an owner their dog's obese when they sit on the chair and overflow over the arms.
Yeah, then it's tricky. Then it becomes really delicate if they're overweight also, actually. This might actually be a good opportunity to jump around a little bit and talk about what the risk factors for obesity are, because we've sort of talked about inactivity and overweight owners, which is one of the risk factors, particularly women, actually. What other risk factors are there?
Overfeeding. Again, I think owners have a misconception of how much food dogs need.
And within that, feeding treats, so particularly owners that are out for periods of the day and give their dog a treat every day and things like that, that tends to be a big jump in the energy consumption and decrease in energy expenditure when dogs are kind of stagnant, lying around eating treats. As far as the kind of signalment risk factors, what would be risk factors in a dog in their signalment?
Yeah, really, really polyphagic breeds like Labradors.
Great.
As well as really cute animals that get a lot of treats.
Yeah.
Yeah, and an urban environment is another, I think.
Yeah, for sure. Back to signalment, we talked about breed. What about sex?
Female.
Female desexed.
Female desexed dogs. What about cats?
Male, entire.
Male desexed, actually.
Sex.
Yeah. So both species desexing is a risk factor. But in cats, it's males overrepresented, and in dogs, it's females overrepresented. And the other breeds that are overrepresented are cattle dogs, as you mentioned, Jeff, and cavies, as well as Labradors, who are the kind of obvious choice. What about related disorders which contribute to obesity?
Well, I would think the immobility from joint pain,
Good.
which is a sort of a vicious circle, isn't it?
You're thinking like a GP, Jeff. What about medical conditions?
Hypothyroidism.
Yeah, good. Excellent. Any others?
I guess Cushing's could increase fat deposition, but they often have muscle wastage.
Definitely, yeah. And that's probably a good point to raise, and one that was kind of one of those light bulb things in the earlier chapters on nutritional assessment. In each animal, we should be doing, in our kind of assessment of condition, we should be doing both a body condition score, which relates to fat, but also a muscle condition score, which relates to sort of lean body mass. Because both of those can be, you can have a really overweight Cushingoid dog who's got terrible muscle condition. And that just really helps sort of as a descriptor of where nutrients are being used and stored. The other sort of risk factor that I don't really know how to put in, to give people hints about, is that dogs belonging to older people or cats belonging to older people, particularly when there's dementia or memory loss and an inability to sort of feed consistent amounts. They tend to feed extra rather than underfeed as a rule.
There'd be occupational hazards too, like nursing home dogs are very prone to obesity.
Yeah, absolutely. Nursing home dogs need muzzles on at all times.
Whereas a working sheep or cattle dog wouldn't be.
Yeah, absolutely. And that then other risk factor, which we sort of talked about, is activity. Inactivity obviously predisposes to obesity. All right, let's jump back to conditions which are affected or impacted by or exacerbated by obesity. We've done osteoarthritis and idiopathic cystitis. What others?
Well, cardio. Go on, Josh.
You go.
No. I'm only here for the beer. And there isn't any.
Oh.
That's disappointing. I was going to say like fat cats and diabetes. Correct.
Excellent. And in fact, obesity in all diabetes will impact insulin sensitivity, but cats are particularly sensitive to the impacts of obesity. Do you know why that is?
Insulin resistance. So I think it just affects the insulin receptors directly, but I'm not sure exactly what the pathway is.
Yep. That's pretty accurate. It's actually the increasing fatty acids in circulation in obese patients, which directly decreases insulin receptor function. So you get a local, just circulating fatty acids cause insulin resistance, but then obesity is also very pro-inflammatory, and we'll sort of go into that a little bit more. But inflammation also impacts insulin sensitivity, so it kind of steamrolls a little bit. The other sort of endocrine impact of obesity is that adiponectin, which is one of the hormones associated with, one of the hormones associated with adipocytes. Adiponectin is actually decreased in obesity, and that exacerbates insulin resistance. It decreases fatty acid oxidation in the liver and increases glucose secretion. So it's kind of anti-insulin effect. So increases the glucose in circulation, where you've got the fatty acid suppressing the insulin receptor. And then you can see why you then need more insulin to get rid of the extra glucose you've got. And then eventually your beta cells are going to get exhausted. So we're going to obviously cover diabetes and insulin resistance separately in a lot more detail as we get through those chapters. So I won't go too much more into that. Any other conditions?
Probably more of a surgery one, but things like airway issues.
Right.
So brachycephalic breeds or dogs with like polyneuropathies and what's it called?
Laryngeal paralysis.
Yeah.
Well,
They tend to do, and especially like elongate soft palates, tend to do quite poorly if they're fatty.
yep, absolutely.
Or there's difficulty in breathing because there's so much thoracic fat and generalized fat.
Absolutely. And if you think about, you look at the x-rays of fat animals and you sort of see the thorax and then you see this much fat, 50% of the width of the thorax again sitting on top of it. It's a lot to lift. So obviously the respiratory muscles are going to be working harder. Tidal volume is going to be decreased in a fat animal just by way of pressure on both the diaphragm and the external thorax. And then when you couple that with another disorder, the respiratory function is going to be compromised for sure.
Overheat as well.
Beg your pardon?
And they overheat.
Yeah, absolutely. And they tend to pant more because it's much easier to move the diaphragm just a little bit than take big, deep breaths. The other condition, which is quite medical, which I think is impacted a lot by obesity, is tracheal collapse. When they've got increased pressure on their upper airways, the sort of soft part of their airways, they've got to suck harder on inspiration and they've got to push harder on expiration. And you can imagine whether they've got cervical or intrathoracic tracheal collapse, that's going to impact the degree of collapse, that sort of negative pressure or positive pressure. I've seen dogs with tracheal collapse who I've just put on really strict diets, like I cut their food by 50%. And when the owners are compliant with that, the improvement is profound and it keeps them much less medication dependent for a lot longer, in my experience. What do you reckon, Jeff?
That's interesting. I hadn't noticed that, but then again, I haven't diagnosed that many tracheal collapses. So I'm just trying to think back as you're talking. I remember one distinct in England. I used to see a few, and I'd put them on ACE and butorphanol, or you could get butorphanol tablets there then.
Yeah.
And that seemed to, because it decreased their anxiety and decreased their respiration. It seemed to help. But I don't remember them being overweight. But God, that's decades ago. I just don't remember really. No, look, I really can't comment on that actually. I can see what you're saying, and I can see why it's got to be right. And the other thing that I have seen in a Frenchie in Adelaide, and I think that dog was obese, was right-sided cardiac failure, which followed on from the lung damage from what you just described. And we had cor pulmonale.
Oh, right. Interesting. Frenchies that's actually a really good demonstration of what negative pressure in the airways can do to both cardiac and pulmonary function. Frenchies and brachycephalic dogs have altered baroreceptor activity and they're more prone to aortic root tumours because there's such a change in the pressure in their chest so consistently that their baroreceptors are essentially overstimulated and inflamed, and they're much more prone to tumours of those cells. Quite profound what pressure on the upper airway can do. So respiratory, we've covered cystitis, diabetes, osteoarthritis. What other disorders are associated with obesity? I think you mentioned cardiovascular, actually, Jeff.
Yeah.
Cardiovascular.
Well, if there's a lot of fat in the chest, the heart's going to be constricted a bit.
Yep.
And the fat in the chest is going to limit the expansion of the lungs as well.
Yep.
As well as like the abdominal fat limiting the diaphragm.
Mm-hmm.
But I suppose if they're going to then get an aortic body tumour, then they can get pericardial effusion, which now that you mention the brachycephalic thing, that I saw a bulldog in Wagga, which gave me great teaching material too. And when I saw the dog and saw the ECG that the referring vets sent, I thought, oh right, you've got pericardial effusion.
Yeah, right.
And he did have, as he just proceeded to collapse in the consulting room.
Oh God.
But yes, he was overweight too, I think. Yeah.
That was an English bulldog, did you say?
Yes.
Yeah.
And I remember thinking, I had some instinctive thing in my head that they were prone to aortic root tumours.
Yeah. Definitely. So it's a lot of different impacts on the cardiovascular system, but one that we haven't mentioned in the process of that discussion is the hypertension associated with obesity.
Hypertension.
Hypertension. Yeah.
The atherosclerosis.
Interesting in humans, yes, but not so much in dogs. There's a couple of different factors actually, and I will just jump around, so not going in the order of the chapter at all at the moment, but essentially adipose tissue is the source of angiotensinogen. What does angiotensinogen turn into?
Come on, Josh. That's not hard.
Angiotensin?
Yeah,
well, exactly.
Yeah.
1 and 2?
Yeah, exactly. So the pathway is angiotensinogen, angiotensin 1, angiotensin 2. So if you've got more adipose tissue or more adipocytes, you get more angiotensinogen. And what effect is an increase in angiotensin going to have on fluid, on vascular tone? Let's say vascular tone.
Increase.
Good.
Plus, you'll probably also get sodium retention.
Good. Via activation of the aldosterone
and
system.
Probably get increased glomerular pressure as well.
Yeah, excellent. So we get systemically, we get fluid retention, a sodium retention, which results in fluid retention, and increased vascular tone. So we've got two mechanisms for hypertension, which is going to be self-sustaining. So normally there's kind of these negative feedback loops which prevent that from happening. You know, obviously increased blood volume, more blood flow to the kidneys, increased GFR, decreased blood volume. But then when you've got this ongoing like angiotensinogen being overproduced, you've just got this balanced shift towards fluid retention. Does that make sense? Yeah, I thought that was really interesting as far as the impact that that will then have on heart health. Max, tell me what effect on the myocardium, the left ventricle, will get from hypertension.
It's likely to get to start with concentric hypertrophy.
Excellent.
And then by time it may get eccentric because it just keep pumping against pressure.
Exactly. So we're going to essentially, when we've got pressure overload from hypertension, we're going to get concentric hypertrophy, thickening of the myocardial wall. It's a muscle that has to work harder and therefore it'll get bigger. And then over time, as we get fluid retention, we're going to have increased volume inside the left ventricle, which is going to mean that the thickening is, the internal diameter is still normal, but the thickening is eccentric. So it's going to be a combination of eccentric and concentric hypertrophy in this condition. what impact might that have on a dog with degenerative mitral valve disease?
You increase the regurgitation volume across the mitral valve back to the left atrium, and then they can progressively increase the pulmonary venous pressure and resulting in pulmonary edema.
Excellent.
Okay. And the base cause of that is the expansion of the heart pulls the valve leaflets further apart.
It's one of the causes actually, but there's the second cause is during systole, the left ventricle and the aorta are in equilibrium pressure-wise. So the systolic blood pressure is equal to the left ventricular pressure during systole.
Mm.
So if you've got increased pressure in the left ventricle, you're going to get increased regurgitant fraction through the mitral valve.
Yeah.
So you're actually going to get exacerbation of mitral regurgitation as well, and therefore that left atriomegaly and increased pulmonary pressure will accumulate faster than if you had a low systemic blood pressure. Make sense?
Yes, it certainly does.
Interestingly, an obese patient diagnosed with congestive heart failure in both humans and dogs, not applying to cats, actually has a favourable prognosis, which I thought was really interesting. So that's from the point of being diagnosed with congestive heart failure. Because most patients with congestive heart failure are cachectic. They have cardiac cachexia. Is that how you say that word?
Yep.
Yeah. Okay.
That sounds familiar.
Good. So the absence of weight loss is a positive prognostic indicator. So it's not necessarily that the obesity is protective, but it's that the disease isn't as bad despite it looking pretty similar because they haven't got that cachexia and loss of muscle condition. It's also obese patients will get diagnosed earlier because they're less tolerant of the respiratory and like exercise. They're already exercise intolerant, so they're going to be diagnosed with only a little bit more exercise intolerance, if that makes sense.
It does.
So it's actually interesting if you've got a mildly to moderately obese, not morbidly obese, but mildly to moderately obese patient with heart failure, better prognosis marginally. We've been talking about the RAS, the renin-angiotensin-aldosterone system. So one of the other conditions that obesity impacts is involved with that hypertension. What might that be? What are the target organs with hypertension?
That question. What was the question?
Sorry, I worded it really poorly. I was hoping you got it.
I've got bad internet here for some reason.
So we've been talking about obesity causing hypertension, and we're also trying to identify the body systems which are impacted by hypertension, by obesity. Given we're talking about obesity causing hypertension, what disease process would be exacerbated by obesity that we haven't talked about yet?
Kidneys.
Good, excellent. So Josh, you actually alluded to this. You get increased glomerular blood flow, and you actually get increased sympathetic nervous system activation locally at the kidney. So you actually get glomerular hypertension associated with obesity on top of the systemic hypertension. Sorry. So definitely there's same sort of proteinuria and glomerular hypertension, which can increase progression of renal degeneration. The other thing about obesity is that there's increased fat turnover. So you sort of think, well, they're fatter, but there's actually increased lipolysis and lipogenesis happening to replace and keep that fat cells healthy. And some of the metabolites of fat metabolism are nephrotoxic. So there's also increase in inflammation in the kidneys associated with obesity because they're constantly processing low levels of nephrotoxins from the fat turnover. So any patient with other predisposing, so obesity in itself won't tip a patient into renal failure, but it will exacerbate renal compromise. So any patient that has renal compromise already, being leaner is going to decrease the impact on their kidneys. There's a couple of other ones that I'll sort of talk about, but I guess obesity in humans is associated with cancer. Has anybody seen any papers or anything written about canine or feline patients with associations with obesity and cancer? No. There's not much out there actually. I think probably because our patients don't live quite as long and they're often not obese for quite as long. Therefore, the sort of chronic ongoing inflammation isn't as much of a problem as with humans. Interestingly, in humans, obesity is associated with endometrial, breast, and kidney cancers. These are all cancers we just don't see very often in our patients as well. Obesity is not associated with colorectal, pancreatic, or prostate cancers. So they've been able to separate all of those. And they're maybe cancers that we see a little bit more commonly. And there's no discussion about lymphoma or the cancers that we see most commonly in companion animals. In both colon and breast cancer, leptin is one of the mediators of that. So increased leptin levels increase cell proliferation. So they actually provide growth factors to the cancer cells, and it has anti-apoptotic effects. So it decreases cell death and increases cell division in both colon and breast cancer. So that's leptin. So let's now jump back in the chapter to what leptin is. Essentially, leptin is the anti-obesity hormone. So every time you eat a meal, leptin is produced from the gastric mucosa and adipocytes. It binds to a receptor in the brain, so it has to cross the blood-brain barrier. And the result of that, so every time you eat, you get a surge of this leptin hormone, and it decreases your appetite and increases your energy consumption, essentially. So it gets you to move around more, increases your metabolic rate. In obesity, presumably that hormone level would be high, right? Because you've got increased levels of, you're eating more, you've got increased requirement for appetite reduction and increased energy expenditure. But what actually happens in obesity is that leptin can't get across into the brain. So it decreases transport across the blood-brain barrier, and you develop resistance to leptin. So the actual leptin hormone level is elevated in obesity, but the effect of the hormone is lower than in lean patients. Does that make sense?
Yeah. What stops it getting across the blood-brain barrier?
Don't know, actually. So then the other effects of leptin are angiogenesis, suppression of apoptosis, it's pro-inflammatory, and it stimulates cell division. So it contributes to cell proliferation. So all of those things in obesity, there's increased levels, and all of those effects of leptin are increased, except for the appetite suppression and increased energy consumption effects. So it's quite sort of deleterious in obesity and self-perpetuating as well. So it actually perpetuates obesity by not having those appetite suppressant effects. So if we then sort of look at that, how it associates with cancer, those effects of angiogenesis, cancer needs good blood supply, suppressing apoptosis. Normally, apoptosis is one of the body's defense mechanisms for a mutated cell. So it just dies off and doesn't go any further. If it suppresses apoptosis, then there's more opportunities for cancerous cells to divide. It's mitogenic, so it stimulates that cell proliferation, and pro-inflammatory. So it's going to increase both blood supply and also recruit cells, inflammatory cells to the area, and have the other systemic effects of increased inflammation. So lots of potential links to cancer, but none that we really see in companion animals yet. And the only other one, I think that flows on quite nicely from the cancer one, is the effect of obesity on just general systemic inflammation. Through these rounds, we did a fair bit of critical care and the kind of generation of inflammation. Does anyone remember tumor necrosis alpha from those discussions? TNF alpha?
Mm-hmm.
Blank faces. So the big two cytokines which cause the initial sort of surge of inflammation, the tumor necrosis, TNF alpha and interleukin 6.
Yeah. Sure, I remember that.
Hey?
I remember that.
You remember that?
Yeah.
So what happens in obesity is that I'm just going to find my summary of this, sorry.
Yeah, it was good to hear that, because all those things were invented since I graduated.
All the TNFs and ILs.
Yes.
Yeah.
Yes.
I'm amazed, actually. I don't know whether research has slowed down, but over the last 30 years or 50 years even, so all of these, this chapter talked about leptin, adiponectin, angiotensin, resistin, apelin, visfatin, cholecystokinin, glucagon-like peptide, all of these things. Like, when was this research done? How did they discover all of this? It's really amazing.
Well, I think one of the factors there is the what would you call it? The animal welfare factor, making it so hard to do live studies. Because a lot of these were discovered when you didn't have to be fussy about how you treated your research subjects.
That's actually a really good point.
I'm not saying it's a bad thing.
No.
But I'm sure it's had that effect.
Absolutely, slowed it down. There's also, I guess there's not many vets. Maybe vets were more academia, like more associated with universities originally, where it's become more privatized. I don't know.
Yeah, I sort of doubt that, but yeah, maybe it could be. I think, well, I only ever tried to get one thing through what do they call them? The CSU's ethics committee.
Yeah.
Crikey, talk about a to-do.
Yeah.
And not the sort of thing you want to do unless you're absolutely determined.
Yeah. Yeah, no, that was one of the biggest turn-offs for research for me, all of the paperwork associated with animal studies.
Oh, and the cost. I mean, it probably cost, I couldn't believe when the dean said we'll allow about 1,000, 1,200, and I thought this was crazy, but it wasn't.
Yeah. So the tumor necrosis factor alpha is increased in obesity. I just can't find where I've written this down. Something about macrophages. Oh, there. Okay. So tumor necrosis factor alpha and IL-6, and the way that they then impact insulin sensitivity is that they directly increase hepatic triglyceride secretion and they reduce hepatic insulin sensitivity. So if the liver is less sensitive to insulin, it can't get glucose into the cells. The intracellular glucose concentration drops, causing lipolysis or lipid breakdown as an energy source, because the liver thinks that we're hypoglycemic, despite what the blood glucose is. So inflammation decreases insulin sensitivity at the source at the liver. You end up with increased fatty acids in circulation. And what effect do they have on insulin receptors?
Deactivate?
Yeah, exactly. Yeah, so they block insulin receptors and cause peripheral insulin resistance. So we've got hepatic insulin resistance from the inflammation, and then we've got peripheral insulin resistance from the result of that inflammation. So the other potential pathways that inflammation can contribute to insulin resistance is that there's a retinol binding protein, which is increased with increased adipocyte levels, so producing adipocytes and associated with obesity, which actually inactivates the GLUT4 receptor or GLUT4 channel. What does that GLUT4, GLUT4 do? Anyone?
That sounds familiar.
Sounds familiar.
Wait a second.
So essentially it's a glucose transporter, transports glucose from extracellularly to intracellularly. There's GLUT1, 2, 3, and 4. GLUT4 is the insulin dependent one. So it's the channel that's on hepatocytes, adipocytes, and skeletal muscle cells. The brain has GLUT1, which is not insulin dependent. So glucose can always get in regardless of insulin level. Is that all right? So any condition which is exacerbated by inflammation, which causes physiologic stress and all of the rest of it, will be exacerbated by obesity, essentially. So that kind of covers the impacts that obesity can have on health. How interested are you guys in the different hormones that adipocytes produce and the control of appetite and stuff from the GIT?
So we should work on it.
Do you want to do a little bit on that?
Mm-hmm.
Okay, so we talked about leptin. I'm going to test who was listening. Can someone tell me what leptin does?
Decreases appetite.
Decreases appetite.
Yes, and
Apparently, it can increase production in the choligotropic releasing hormone.
Can it?
Is that right? Oh, yes. I think so. Yeah, I was just checking my notes. I didn't remember.
Oh, good. Yeah, that's interesting. So it increases corticotropin releasing hormone.
Yeah.
Right. Okay.
So because of that, I don't know how it said it will reduce food intake because it increased.
So it binds to the OB receptor in the brain apparently to decrease appetite and increase energy or increase metabolism. And then it has all those angiogenic and potentially neoplastic properties as well. So that is synthesized in adipocytes predominantly, but also gastric mucosa after a meal. The second hormone that the adipose tissue, or adipokine, not hormone, that the adipose tissue secretes is called adiponectin. Adiponectin increases insulin sensitivity and decreases blood glucose levels. So blood glucose gets into cells more easily under the effect of adiponectin. It is decreased secretion in obesity, and therefore you kind of get the loss of that insulin sensitizing effect in obesity, in addition to the effects of the inflammation and stuff. Does that make sense? Kind of,
Yeah.
I feel like I've worded that with a lot of double negatives. Sorry. Adiponectin is a really nice chemical because it decreases inflammatory responses, decreases triglyceride concentrations, and therefore circulating fatty acids. So in health, it's very protective, but the fact that its levels are lowered in obesity is exacerbates the inflammatory responses and insulin resistance in obesity. So we've got leptin, which is normally would protect against obesity, but in obesity, the effect is lost. We've got adiponectin, which normally sensitizes and improves glucose utilization, but those protective effects are lost in obesity. We've got angiotensin and the RAS activation, all secreted from adipocytes, and the effect on blood pressure associated with that. The next one on the list is resistin, which is a cytokine which is a chemoattractant, so increases macrophages in fatty tissue and increases the inflammatory cytokine production from those macrophages. Apelin, APELIN, is also produced from adipocytes, but it's actually protective in that it antagonizes the effect of the angiotensin. So it causes vasodilation and is cardioprotective. And then visfatin is the last thing that was listed as produced by adipocytes, and this is not an exclusive list, this is just the ones that they understand what the effects are. So visfatin, VISFATIN, is predominantly produced in abdominal fat rather than the subcutaneous fat. So if you think about those Cushingoid dogs or dogs that are holding a lot of truncal obesity or abdominal fat as opposed to subcutaneous fat, they're going to have increased levels of visfatin relative to other animals. Visfatin binds the insulin receptor and decreases the hepatic release of glucose. So actually works like insulin. It causes glucose storage and increases adipocyte uptake of glucose. So similar effects to insulin, binding on the insulin receptors. So they're the 7. Leptin, adiponectin, angiotensin, resistin, apelin, and visfatin. So there's really, in obesity, there's a lot of, in health, there's a lot of sort of protective mechanisms in these hormones and adipokines, but in obesity, we lose a lot of that regulation. So then the next 3 enzymes that they talked about are produced from the GIT in association with eating. The first one is, the first one is ghrelin. Can anyone spell ghrelin for me?
Gh.
Good.
Ghrelin, Len.
ELIN. Yeah. GH. Just thought I'd test you on that. So do you know what ghrelin does?
Oh yeah, ghrelin is, it makes you hungry, because I keep thinking if you're hungry, you make this ghrelin noise in your stomach.
Ah, what a good way to remember it. That's exactly right. So it's produced after fasting and is suppressed by eating. So ghrelin, would you know what happens with ghrelin in obese states? Could you take a guess?
Yeah, it's increased.
It's actually decreased.
I thought they make you, but
More hungry.
yeah, I thought like if you're fat, you're more likely to eat more. Oh no, that's because of leptin resistance.
Yeah, potentially leptin resistance.
Oh.
Yeah. I don't know what the mechanism is, but so I thought that was surprising as well. So ghrelin level. So ghrelin is the thing that makes you hungry. So when you're fasting, makes your stomach ghrelin. Yeah, good, like it. You eat it and it's suppressed. So in obesity, you don't get as much hunger drive. So you might eat the same amount, but you shouldn't get as much hunger drive. But interestingly, after eating, the level of suppression is not as profound. So normally in health, you got a lot of ghrelin and then it's suppressed to almost nothing after eating. Whereas in an obese person, it sits sort of here normally and only goes down to here after eating. So it's just that sort of satiety is not, or the change is not as significant. So overall sort of baseline ghrelin levels might be decreased during fasting, but over a 24-hour period, ghrelin might actually be increased. The next hormone is cholecystokinin. What's that?
That's I think that cholecysto, it's increase the gallbladder contraction.
Good. Yeah. So increases pancreatic and biliary secretions. So stimulated from the L cells in small intestines from eating. Eating stimulates production in the L cells. It decreases gastric emptying. So it makes you feel fuller for longer. And it causes central appetite suppression. Cholecystokinin has no link with obesity whatsoever. So whilst it's really important in satiety and hunger, it's actually, the level is not impacted by being obese or not. Glucagon-like peptide. Does anyone know what that does? Can you guess from the name?
Increase blood glucose?
Yeah, essentially, yeah. Well, no, sorry. So glucagon-like peptide, it looks like glucagon, but it doesn't act like glucagon. So it's a little bit confusing. So what it actually does, it's produced from the same cells as the cholecystokinin, the L cells in the small intestine, and it actually stimulates insulin secretion from beta cells and suppresses glucagon secretion from the alpha cells in the islets. So after eating, you get that spike of insulin. We all know about that. And that part of that is the glucagon-like peptide increasing insulin secretion. That happens, that glucagon-like peptide secretion happens before we used to think that you eat and your blood glucose spikes and that stimulates insulin secretion. Glucagon-like peptide causes insulin secretion before your blood glucose is spiked. So it dampens down that blood glucose spike that would have happened in response to eating normally. It gives the insulin a bit of a head start. It also centrally decreases appetite suppression and is interestingly increased in obese dogs. And remember that dogs have quite different glucose homeostasis than cats and humans. So it's actually decreased in obese people. So they don't get as much insulin secreted in response to glucagon-like peptide, but increased in obese dogs. And that's sort of one of the differences between species that maybe affects the predisposition to type 2 diabetes. So that's all the like really important enzymes and stuff that they talked about in this chapter. And really, we've pretty well covered all of the stuff that I wanted to cover, apart from reproductive hormones. So we talked about neutered status being contributing to obesity. Can anyone hazard a guess why?
With lower metabolic rate, wouldn't it?
Yeah.
Desexing.
Yeah. So it's via the just reduction in the sex hormones, and predominantly estrogen is the one that's best studied, and that's kind of extrapolating from human literature and the shift in metabolism in women after menopause with decreased estrogen levels. But essentially, estrogen normally decreases adipocytes and lipogenesis, so just decrease fat production in animals with estrogen in their system. Take away the estrogen, you get increased adipocyte formation and increased lipogenesis, so formation of fat. So there's a shift from sort of depositing lean body mass to depositing lipid in the way that we process excess energy consumption. Neutering also has an impact on the satiety centers. So they're after a meal, there's decreased sort of sensation of satiety in neutered patients, and decreased metabolism. So actually decreased metabolic rate associated with decreased sex hormone levels. And that sort of explains why female dogs are overrepresented, but not why male cats are overrepresented. And that is obesity.
Yeah, thanks, Hannah. That was really good. Also very, very complex. So, I mean, Josh and Max won't be going out at night for the next week because there's so much study in that.
Yeah.
But if you could give more notice of the subjects, that'll give us time to study it. Now that I've blown my excuse about the old edition, I'll have to be more attentive to it in future.
You have to up your game.
Yes, I will.
Can I tell you now, Jeff, what we're going to do next week?
Yes.
Next fortnight?
Next fortnight.
So in the new edition, it's chapter 178, which is nutritional management of gastrointestinal disease, exocrine pancreatic disease, hepatobiliary disease, and endocrine and metabolic disease.
So just could you list those again? Nutritional management of
gastrointestinal disease.
Yeah.
Exocrine pancreatic disease.
Yeah.
Hepatobiliary disease. And endocrine and metabolic disease.
So that was chapters
178 to 181.
178 to 181. Right. Okay. So so Josh and Max have got no excuse next time.
That's exactly right.
Yeah. All right.
Thank you.
Thank you, Anna.
That's a
Thank you.
pleasure. I'll see you guys soon.
Yeah.
Bye.
Thanks, Anna.